My name is Keith Gibson, and I am the State Director for Diversity, Equity, and Inclusion for the Alzheimer's Association, and I'm one of 3 research champions. So it is my honor to be able to be part of this discussion this afternoon. We have our first 2 speakers are from the University, Florida State University, so I'll give a brief introduction and I'll turn it over to them. Our first speaker from Florida State University is Dr. Robert Glukoff. He's part of the ACTS-2 project and a professor at Florida State University College of Medicine. Dr. Glukoff attained his MS and PhD degrees in clinical psychology at Florida State University. His primary professional interests lie in the development and education of skill building and support programs for family caregivers of older adults with dementia and spiritually and health. He is actively involved in his faith community and is a strong advocate for social justice and health equity. Dr. Glukoff is also a daily practitioner of prayer and meditation and a discipline which guides and positively influences all phases of his life. And then also joining Dr. Glukoff from Florida State University is Ms. Tomika Norton-Brown. Ms. Norton-Brown is a project coordinator of the ACTS-2 project. She has worked in the area of survey, development, and evaluation for the past 21 years. She has served as a caregiver for her aunt and uncle with dementia and has a passion for helping others. Ms. Norton-Brown has been a great source of encouragement and support for hundreds of family caregivers of older adults with dementia across Florida. She also is a strong leader by example in her church community. Without further ado, let's give both Dr. Glukoff and Ms. Norton-Brown a warm round of applause.
Welcome, everyone. It's a great pleasure to be here at the Caregiver Empowerment Conference. We want to thank Charlotte Mather Taylor for organizing this event. And should we just go ahead, I think, Tomika, and begin our presentation? Yes. We have Tomika Norton-Brown, who is project coordinator for the ACTS-2 project, also known as the African American Alzheimer's Caregiver Training and Support Project 2. And I'm Dr. Rob Glukoff, the director of the program. I actually prefer to use the term servant leader of the program. And I will bring up the slides. Take it away, Tomika.
Okay. Good afternoon again. As Dr. Glukoff mentioned, I am Tomika Norton-Brown. Our collaborators are the African Methodist Episcopal 11th Episcopal District, the Florida General Baptist Convention, Florida State Primitive Baptist Convention, the Florida Progressive Missionary and Educational Baptist Convention, and the FSU College of Medicine. Next slide, Dr. For our presentation, we have a few objectives. The first is we're going to provide an overview of the ACTS-2 faith-based skills training program and other caregiver services. We will describe the characteristics of Alzheimer's disease and related dementias. We're going to talk about and discuss common warning signs of dementia. We'll identify dementia risk factors and prevention methods, and then deliver information about dementia care resources. Next slide, Dr. G. I will also mention that Dr. Glukoff and I will be doing this presentation together, so there will be portions he will cover and portions that I will cover. Firstly, what I'm going to do is just talk about my journey having been a caregiver. I was a caregiver for my aunt and also my uncle, both who had dementia. My aunt passed away. It's been almost 8 years ago. I worked in this program when I was her caregiver, and I'm very open and honest about the fact that I did not take advantage of resources that were available to me while I was her caregiver. She lived in the Winter Park area. I live in Tallahassee, and I traveled every Friday to go down to make sure that she had medications, that clothes were washed, that food was prepared. For them to have for the upcoming week. And then the next Friday, I would do it all over again. I was working in this program, telling other caregivers to make sure that they take care of themselves, to live their best life. And behind the scenes, I was the person developing anxiety and insomnia and high blood pressure and all of the things that come from trying to do it all on your own and not wanting to reach out and take advantage or take help that's offered to you. So I'm very open about what my journey has been. I often say that it's nothing that I would have chosen for my life, but looking back on it, it's nothing that I would change either. It has made me into who I am. It has given me an insight and shown me that I have a strength that I didn't know I had before. And when I'm speaking to caregivers, I can actually say to them that I truly understand what you're going through. I truly understand that hesitancy to let other people in and to let them know that you're having a hard time. So I try to make every day a day where I show up and be there to be that lifeline for those caregivers. That's why I'm very passionate about what we do and why being a part of Acts 2 is not just a job to me, it's a part of my lifelong ministry. And I honor my aunt and uncle by doing this type of work. I mean, that's just a little bit about why what I do is so important and the connection I have with caregivers. Next slide, Dr. G. Okay. What I'm now going to do is to give some information about our Acts 2 project and our program of services. We have three major type of services, and I often describe this as branches of a tree. On the first branch, we have faith-based group skills training and support for distressed African American caregivers of older adults with dementia, and I'll provide more information on that in a moment. You'll hear me referring to that as our 12-session program. We also do things like this. So we do dementia awareness presentations and workshops at faith community and elder care venues, as well as through print and social media. And then we have brief individual telephone-based consultation and referral services to dementia caregivers and other stakeholders. Now, I will say that for the 12-session program, in order to qualify, you have to be an African American, relative, loosely defined, relative caregiver of an older adult with dementia and spend 6 hours in your caregiving duties. Now, for number 3, those brief individual telephone-based consultation and referrals, that is open to any person anywhere in the U.S. So if someone calls up and says, hey, who provides respite in my area? I live in Louisiana. We will spend some time speaking with them, finding out what needs need to be met, and then we would research and provide them links to resources in their community. So I just want to differentiate that the 12-session program, African American Caregiver, State of Florida, and the brief telephone-based referral and consultation is open to anyone, regardless of race and or location. Next slide, Dr. G. In our 12-session program, it includes 7 group skills building. So there's 3 caregivers in a group and 5 individual sessions. All of the sessions are delivered weekly over a toll-free telephone by what you will hear us refer to as trained lay pastoral care facilitators. And those are simply lay persons, so not pastors, from the faith community who we train to be able to deliver the sessions. In those individual sessions, so the 5 individual sessions, with facilitators, they focus on goal setting and problem solving to address the concerns that are identified by the caregivers. The majority of caregivers come to us with 2 or 3 things that they want to work on, whether they be caregiving goals or personal goals. And they actually get 5 weeks of one-on-one time with the facilitator where they can work on strategies that will help them achieve those goals. Next slide, Dr. G. Okay. Our program consists of 6 major components. The first is an overview of the basic characteristics of the dementias, or what we'll refer to as Dementia 101. There is relaxation training that's combined with calming prayer and or meditation. And let me also add here that yes, we are faith-based, which means that we have woven in elements such as scripture and faith sharing, but we're also ecumenical. So if someone comes to us and is maybe uncomfortable with doing the prayer or sharing their faith, they don't have to, and it will not stop them from participating in our program. So we actually teach our caregivers on how to relax, how to have mind, body, and spirit into the state of relaxation. We also have effective thinking about the challenges of caregiving that's coupled with scripture, just changing the way you're thinking about your caregiving situation. Next slide, Dr. G. We also have my favorite, I refer to it as the me time module, just building in pleasant daily activities as a guard against emotional distress. So negotiating 15 minutes to be able to take a walk or to listen, whatever your favorite kind of music is. And then we also have communicating effectively with the care partner with dementia, with family and health professionals. And then lastly, developing effective problem solving skills through those personal goal setting. Next slide, Dr. G. Before Dr. Glukov comes, what I'm going to do is to give some demographic information on Alzheimer's disease and related conditions, and this will further illustrate why it's so important for us to get the word out specifically to the underserved populations. The prevalence of Alzheimer's disease and related dementias in the U.S. is approximately 6.2 million. So over 750,000 Floridians are estimated to have some form of progressive dementia. So if you think that there are over 750,000 Floridians with some form of dementia, and if you add one or two or more caregivers to that, then the actual number of people affected just grows exponentially. And although dementia affects the entire population, this syndrome of disorders is spread unevenly across racial and ethnic groups, and older African Americans are twice as likely to develop Alzheimer's disease and other dementia than older non-Hispanic whites. And the clinical etiologies of dementia differ between African Americans and non-Hispanic whites, with vascular dementia or stroke-related dementia accounting for a significantly larger proportion of cases among African Americans. Now, Dr. Glukov is going to come and do some Dementia 101 with you.
Yeah, before I start, I just wanted to let you know that similar to Tamika, I am a care partner for my wife who's in the early stage of dementia. So as we go through this, both of us are deeply committed to promoting the welfare, to honor the preferences of persons with dementia and their care partners. So first, I'm going to give you the umbrella term, which is dementia, and then we're going to focus on the specific types of dementia. Dementia, folks, is as I said, an umbrella, an omnibus term for progressive loss, significant loss of memory and other mental functions that affect daily activities. So what is dementia? So if you were to go to a physician, to a neurologist, to your family physician, these are the characteristics that would lead to a potential diagnosis of dementia. Of course, this is just the what they would call the clinical component, and there would be a variety of assessments associated with this. But this is essentially the meat and potatoes of the diagnosis of dementia. First, there must be significant memory loss. Then there are common elements or features associated with memory loss, activities of daily living, such as problems with language, not being able to express your ideas and opinions in a logical and coherent manner, not being able to do those activities that most of us take for granted: dressing, eating dinner, using a telephone. These are common activities of daily living that are affected by dementia. Another key feature of dementia is using familiar objects incorrectly. So if your mom with dementia used the toothbrush that she had on the right side of the sink instead of her brush to comb her hair, that would be an example of not being able to use an object correctly. Of course, I don't have that particular concern myself, but this is a common feature of dementia. Another example might be difficulty using a remote control to manage the television set, not being able to dial the telephone, which requires a sequence of skills, being able to pick up the phone, push the button, wait for the dial tone, of course, dial the number first, and then respond to the other person on the other end of the line. These are steps in very familiar activities which we would normally take for granted, but these are behaviors that are affected by memory loss, linking those various activities and dialing the phone and speaking to the person on the other end is affected by memory loss. Personality changes are a common feature of the dementias, not being able to communicate with mom, who was your confidant, who would be your person, your biggest supporter, and communicate with her in the same manner, because now she's become periodically your biggest critic. For example, if you were to go away for 3 hours, it might be when you come back, mom is saying, "Where have you been? You used to be the most wonderful son that I've ever had, and you're letting me down. You don't love me anymore." These are personality changes that are affected by the condition. And then problems with judgment. For example, drawing large sums of money from a bank account, and you are a daughter involved as a caregiver, and then you get the phone call. Mom doesn't have sufficient funds to pay for her utilities. That is an error of judgment that's associated frequently with as persons go from early to middle stages of the condition. So those are the common features of what constitutes or represents dementia broadly conceived. But what are the specific types of dementias underneath that larger umbrella term of progressive dementia? Alzheimer's disease is essentially the largest proportion of conditions that represent the dementia. 65% of all persons with dementia have the Alzheimer's type, which is represented, and I'm sure most of you are familiar, by plaques, fatty substances in the brain that prevent the metabolism of nutrients from the extracellular, the fluid surrounding the nerve tissues and nerve fibers. They don't function, those nerve cells, as well, because there are fatty plaques that are preventing the metabolism of nutrients, the actual survival of that nerve cell. And then, of course, you have neurofibrillary tangles or tangles surrounding the stem of the nerve cell that can lead to the death of nerve cells as well. Then you have vascular dementia that accounts either singularly or in combination with Alzheimer's disease, with another 15% of the Alzheimer's. And then there are a variety of other conditions, most of which you're familiar with: Parkinson's dementia, with dementia of Lewy bodies type, and other dementias. I'm going to move on to warning signs because we only have a limited amount of time to explore the different types of dementia. Folks, it is very important not only to know what a red flag is for dementia, it's also important to know what is normal forgetting for a person that's over 60 or 65 years of age. I call those normal forgetting moments. It's not a unique term senior moment. So it's important to know what is a red flag for dementia that may require a memory evaluation, a memory assessment, versus what is normal forgetting. I'm just going to highlight one or two of these warning signs. Number one, memory loss that disrupts daily life. What might be a red flag? Well, I would say if Rob, Dr. Glukoff today, would forget his birthday, let's say that's a red flag for Rob to potentially seek out a memory evaluation. Even worse is if I were to forget my wife's birthday. That's a definite red flag. What might be an example of normal forgetting? If I were there with you at the empowerment conference, and if I were at your table and hadn't met you before, we were talking for 5-10 minutes, and maybe 3 hours later, I met you at the restaurant and nearby the conference center. If I didn't remember your name, I would like to think that would be an example of a senior moment for Rob. Let me move on to the second example. Challenges in planning or solving problems. My grandmother would make for me when I was a child, which led to my being overweight actually as a child, I think, a chocolate angel food cake. Then the icing on the cake, I'm not exaggerating, was at least 3/4 of an inch thick. And my grandmother would make that every 2 weeks for us when we visited her home in Miami. If grandmom were to say, I don't know what makes up my chocolate angel food cake, after she's made it every 2 weeks for years for her family, and she's questioning, well, how do I put the cake together? What are the ingredients? Red flag for Grandma Lulu. That was my grandma's name, Grandma Lulu. However, if you or I let's say we're 65 years of age or older, were to have a new recipe and we skipped a step in that recipe, I would like to think that's a senior moment. That's an example of normal forgetting. Okay, I wish I could interact with you folks, but I'm going to move on once again for the sake of time. Thank you. Risk factors for dementia. This is an important area for most of us to be aware of. There are two types of risk factors, those that are unmodifiable and those that are modifiable. The top three items are factors that are unmodifiable. For example, age, that cannot be modified. A family history of dementia cannot be modified. Having the APOE4 gene, which transports fatty substances, cholesterol, those are all unmodifiable factors. In fact, older age is the strongest predictor of who develops dementia. Approximately 5% of all folks who are 60 to 65 years of age have some form of dementia, and that increases every 5 years, another 5%, until approximately 40% of all persons who are 85 years of age or older have some form of dementia. That's a factor that's age is a strong factor of dementia, but that's unmodifiable. However, fortunately, most of the risk factors that account for the likelihood of developing dementia are modifiable. Then those include the development of type 2 diabetes, being overweight, having high blood pressure, lack of physical exercise, the amount of intellectual and social stimulation, and the impact of and brain injuries, which are preventable. So I'm not going to go into detail on this, but let it just suffice to say that diabetes is a very strong predictor of both Alzheimer's disease and even more so for vascular or stroke-related dementia. The same is true for being overweight and having high blood pressure. Lack of physical exercise is a very much a strong predictor of, of, of dementia, but these are all factors that are modifiable. What I mean by that is by your actions, you can reduce the probability of developing these conditions that are listed here, from diabetes all the way down to brain injuries. Now, I'm not suggesting this is an easy set of factors to modify. They're difficult. But I could say that with encouragement and support and good instruction that's grounded in evidence-based intervention, you can reduce the impact of these factors or even eliminate them. And now I'm going to switch to Tamika Norton-Brown.
What I'm going to quickly do is to give information on the prevention of Alzheimer's and vascular dementia. So Dr. G has talked about things that can be changed or can't be changed. And so we're going to talk a little bit about some things that you can do to aid in prevention. So physical exercise, diet, relaxation, and prayer. Making sure to get regular physical exercise, eating fruits, vegetables, whole grains, like the Mediterranean diet, lowering your intake of sugar and saturated fats, as well as relaxation training and meditation may lower the risk of Alzheimer's and vascular dementia. Participating in activities like the conference today. So keeping those social connections and staying mentally active, learning about new things, maintaining strong social connections, keeping mentally active as we age may lower the risk of cognitive decline in Alzheimer's. Very big one, use of car safety belts and fall proofing at home. A strong link exists between future risk of Alzheimer's and serious head trauma, especially with loss of consciousness. So if you're just getting in your car to run down the street to the corner store, make sure that you're putting your seatbelt on. If you have, I call them flying carpets, the little cute rugs that we all put in the kitchen and bathroom, just make sure that you're being very careful about where you're placing your feet so that you don't fall and potentially hit your head. Next slide, Dr. G. Okay, and here are some dementia care resources. There's the Broward Health North Memory Disorder Clinic. There's the Area Agency on Aging of Broward County, the Alzheimer's Association of North and Central Florida, the Florida Department of Elder Affairs. Next slide. The Elder Care Locator, the Alzheimer's Foundation of America, the Alzheimer's Disease Education and Referral Center, and the Elder Helpline. And if you're interested in learning more about ACTS2, if you're interested in learning about how to participate, there are several ways to contact us. You can contact us toll free. That number is 1-866-778-2724. My local to Tallahassee cell phone number, 850-274-4945. My email address, tnnorton@fsu.edu. We also have a website, www.acts2project.org. On that website, there's a button for contact us. You can fill out that form. It will also route directly to my email address. And then on our Facebook page, ACTS2 Caregiver Project, you can send us a message there and we will respond. And then each month or so on our Facebook page, we do free caregiving friendly workshops. They are all geared toward things that are important to caregivers, things that would be helpful to caregivers, and they are free. They're also saved on our page. So if you look under video, you will see all of the ones that we have previously done. We want to thank you all so much for the opportunity to present today. If you would like a copy of our presentation, feel free to reach out me either by phone, 850-274-4945, or through email, tnnorton@fsu.edu, and we will gladly provide a copy to you. So thank you so very much.
Dr. Duncan recently completed his PhD in the School of Social at Barry University. His dissertation focused on the experiences of caregivers of family members with Alzheimer's and related dementias in the Black community. Acknowledging the higher rate of Alzheimer's in the Black community, his dissertation included cultural factors and reasons behind taking on the difficult and stressful role of caregiving. So, with that said, I'll turn it over to Dr. Duncan to share with us his presentation.
Hello. So, good evening, everybody. Thank you for attending, and thank you, Ms. Charlotte and Area Agency on Aging, for giving me this opportunity. As mentioned, I'm just going to share some of the findings because it was a 100 and odd page dissertation, so I'm not going to be able to share everything, but just some of the findings from my dissertation I'm going to share with you today, and then hopefully go through some resources because, as mentioned, I do work with Broward County Elderly and Veteran Services, so we do have a few resources and services that we provide for caregivers as well. Okay, in the way of background, when I did my dissertation, obviously I focused on some of the reasons why this was an important topic to study. Again, some of this information has been shared already, that Florida in particular, but the population of the United States is aging. As we age, I think one of the risk factors for developing Alzheimer's is age. So there's going to be more and more people suffering with Alzheimer's, as the numbers indicate. As has been shared already, Alzheimer's is growing fastest in our community, the Black community, which means there's going to be more and more caregivers required. So obviously I thought that this was a very, very important topic to study. Again, the American Psychological Association, amongst some other organizations, National Association of Social Workers, has indicated that the topic of caregiving is an understudied topic, and especially when it comes to minority populations, is still further understudied. And as mentioned here again, and as we've talked about earlier, caregiving is extremely difficult. I'm sure I don't need to mention that to most of the audience here today. So in the Black community, where there is a growing degree of Alzheimer's, and caring for somebody with Alzheimer's is even more difficult, there becomes that reason or the question, why is it that we take on that role? And that's one of the questions I tried to address in my dissertation. But in the way of what we actually go through, we tend to provide more care than other communities. We suffer, I think, as mentioned in the prior presentation, there are higher risk factors that we endure as well. So, given that there are higher rates, there are more risk factors. Again, raises that question: why do we do it? How do we do it? And again, looking at Mr. Keith's organization, some of the research that I did, again, tries to address this issue, that we do require more and more services. There is a reluctance, as one of the other risk factors amongst our population, for not reaching out for services. And again, why is that? That we have a history of distrust of formal services and the medical profession. Various factors as to the reasons why we have that distrust. There is a high level of discrimination and use of services, obviously, due to that discrimination. So it tends to place us in a situation where we rely on ourselves. And again, we're looking at ourselves to provide care for our own loved ones. That, again, makes us reluctant to use services. So again, the question for the professional side of things is, how do we, and I think Mr. Keith mentioned, how do we get people from the Black community, caregivers from the Black community, more involved in reaching out for services, more involved in research that is going to address their situation? because there are distinctions between the way that people from different cultures go about what they do in terms of providing care for their loved ones. So if we are ever going to really address the situation in terms of providing effective services for our caregivers, we really need to know what those experiences are and how they differ across cultures. So again, this is just a few more findings I took from the Alzheimer's Association, the journal that Mr. Keith was talking about earlier. And again, as you can see, there is, how can I put it? There is a desire for caregivers. I mean, I know I've mentioned that there is a reluctance, but there is a desire amongst caregivers from the Black community to accept or who need services. We do need services, but my research, which I'm hopefully going to get to, basically states that we are willing to accept services, but where it does not take away from what we do as caregivers. And we have this sense of responsibility, or we retain a sense of responsibility as family members. And going by Ms. Tamika's story in the prior presentation, where we have this sense of wanting to care for family members, for a family member. And rather than take on that role or define ourselves as a caregiver, we tend to just take on that role because that's what we do. I'm going to take care of mom, I'm going to take care of dad, I'm going to take care of my spouse, as opposed to seeing ourselves as a caregiver. So I missed the prior slide. I think is extremely important in terms of if we are going to provide effective services, we really need to hear directly from the caregivers themselves, which is what my study was about. Essentially, I did a qualitative study, and I still think it's important to hear directly from the caregivers so we know directly what their experiences are and how to engage with them so that we can find out exactly what types of services they need and provide those services based on their needs, as opposed to just an imposition of respite care, daycare, which are great services, but we really need to address the caregiver's actual experiences. And in doing so, we empower our caregivers to speak up. So this, again, was another theory that I encountered when I was doing my research. Essentially, it talks about, again, that change as you take on that role as a caregiver. Basically, initially you see a family member, and when I talk about caregivers, I'm talking about family members taking care of family members, as opposed to professional or paid caregivers. So when a family member takes on that role, initially it's because it's a family member who needs help, and then as the care recipient, the family member in need of help, their condition deteriorates. When they have Alzheimer's, it's going to deteriorate. It's going to get harder and harder for that caregiver to provide services and help for that care recipient. As it gets more and more difficult, they spend more and more time taking care of that loved one. Their sense of who they are changes. So they change from being a family member providing care for a family member to just a caregiver providing care to someone who needs care, a care recipient. So again, I run through that theory quite quickly. Obviously, it's a little bit more nuanced. I think I heard from a caregiver earlier how eventually that role changes to where the caregiver has their loved one placed, and then the level of care that they provide kind of declines, but they still retain a certain relationship. But then again, I go through it quite quickly, but the reason I mention is that my study basically focused on the Black community. It found that, but not to the extent that the theory proposes. Yes, there is a change in our loved one because they have Alzheimer's and their condition is deteriorating. They no longer remember who their family members are. They no longer remember who the person who's taking care of them is. But the caregiver themselves, the family member, for the most part in my study, stated that they did not change. That is their mother, that is their father. I am going to continue to take care of my mother and my father because that's my mother and father. That's what we do in our community. Yeah, so whilst there was a change, whilst there was an adjustment, whilst there was more time being spent taking care of their loved one, there was this, it was very prominent in my study that I'm not changing. That is who I am. This is who I am. This is what I do. That's what I'm going to do. So I think that from a professional point of view, we need to acknowledge that. We need to help our caregivers to understand that there will be changes. We need to acknowledge that the caregiver wants to retain that sense of family responsibility and family identity. And then we need to adjust and make sure that we provide services that take that into consideration. So at this point, I mean, I would have, if we had time, obviously get into a little bit of discussion about, the cultural nuances amongst the Black community in terms of doing what we do, because that's what we've always done. This is how we grew up. We grew up watching other family members, taking care of other family members. So this comes natural to us. It develops a sense of responsibility that, it's something that we have to do. It develops a sense of conflict in terms of this is what we do, this is what I'm expected to do, but it is difficult for me to do it. We have to acknowledge the fact that it is difficult, and to acknowledge the fact that it is having an effect on me, but this is what I'm expected to do. So there is that sense of conflict that sometimes our caregivers don't recognize or are aware of it. Our professionals need to help us or help our caregivers to become aware of those things or aware of that transition. So in the way of resources, as I say, I do work for Broward County Elderly and Veteran Services. These are some of the services that we provide. I have put case management in capitals because I believe that your best resource, apart from daycare, I think daycare is a fantastic resource, but I think getting in touch with a case manager or a social worker, somebody that is going to help you to navigate the system and help you to hopefully develop a trusting, I think that word was used earlier, a trusting relationship where they are going to fully understand your needs, appreciate the experiences that you go through, and find you the appropriate resource and implement that resource in the most appropriate way that addresses your experiences. Due to time constraints, I'm going to just mention that I think something that was alluded to throughout this conference is about developing that relationship based on a cultural humility perspective. I think that's been alluded, it hasn't been actually said, but I think that a cultural humility perspective where the professional tries to put aside their own biases or their own values and viewpoints and really appreciates and truly listens to where their clients, in this case caregivers, are coming from, and really understand their needs and their experiences, and then apply services based on that relationship and that understanding. So anyway, here's some further resources, which I'm sure everyone has, well, I mean, a whole bunch of resources has been mentioned here today, but this is just a few more. Again, you can call my agency if you need to find out any more resources or how to apply our resources. And Area Agency on Aging is obviously another place where you can go to find out where to access resources. So basically, as mentioned, I think that there is the services that we provide basically needs to take into consideration the change in experiences that our caregivers go through. Primarily that we do want to retain that relationship as that experience becomes more and more difficult, more and more trying, more and more stressful, and we do need services where we probably aren't really reaching out for it. Our professionals need to help us to understand those changes and to help us to understand that there are services out there that can be applied that does address our needs and doesn't take anything away from the fact that we want to retain that sense of responsibility and that family identity. Thank you.
Thank you, Dr. Duncan. That was amazing. Um, just to add to that, I think one of the things that from this current climate that we're coming out of the pandemic, there are three elements that are so crucial and they're universal. We need to extend love, grace, and understanding. And I think those are very critical. And we also need to be aware of our own biases. And as you know was said earlier with Dr. Glukoff and Miss Norton Brown, is that there has to be a cultural change. And that cultural change is particularly in the communities of color, is that we need to not be afraid to let folks know what's going on, because in the Black and the Hispanic communities, it's taboo to say what's going on in your home. You got to get out of that thinking, because if not, you will be passed over. So again, I just want to thank you, Dr. Duncan, for sharing, and then once again, congratulations on your PhD. So with that in mind, I want to move on to our next guest speaker. Who comes to us from the University of Miami, the John P. Hussmans Institute for Human Genomics, Miss Claire Karen Brown, who is the Senior Manager, Research Support at the John P. Hussman Institute for Human Genomics, the University of Miami Miller School of Medicine. She is an experienced healthcare provider who has extended culturally sensitivity professional nursing services in various clinical and research settings to patients across the lifespan. Nurse Blair is board certified by the American Nursing Credential Center as a psychiatric mental health nurse practitioner. Her current role at the University of Miami includes supporting efforts to recruit, enroll, and retain African American participants for the Alzheimer's disease studies. Further, she supports efforts to collect biological samples and phenotype topic data of the African American population for Alzheimer's disease studies. Nurse Blair is currently completing a doctorate in nursing, where her area of interest concentrates on maximum support efforts for caregivers of dementia with Alzheimer's disease. Via speaking engagements and local collaborations, Nurse Blair has been instrumental in bringing awareness to the plight of Alzheimer's disease caregivers and continues to be a force for positive change in this effort. And I would be remiss if I did not give a shout out to her colleague, Larry Adams, who's joining us today, who's in our audience. So with that, let's give Miss Blair a warm welcome.
Thank you, Mr. Gibson, for that wonderful introduction, and thank you to all of you that are here. Thank you to Ms. Taylor for inviting us to this very important event. This is an area near and dear to my heart. As a registered nurse, I spent many moons, many years working in the homes with individuals suffering from Alzheimer's dementia and their caregivers. So I've seen a lot, and those experiences really motivated me to be here at this point in life. So as Mr. Gibson said, I'm coming to you from the University of Miami, where I work with Dr. Parachik Vance, Dr. Vance, Mr. Larry Adams, and we are fast at work on biological research regarding Alzheimer's dementia, Alzheimer's disease. So, Alzheimer's dementia and its impact. This is one of the costliest societal conditions at $250 billion annually to healthcare systems. Most individuals receiving long-term care are community dwelling. Most individuals requiring home care are elderly with dementia. To those living in the community with Alzheimer's dementia, caregivers in the United States provided almost $257 billion, that's with a B, $billion worth of unpaid caregiver services. So informal caregivers, 80% of the individuals diagnosed with Alzheimer's dementia are usually cared for at home by friends, family members, and other unpaid individuals. The majority of the caregivers are female. Female caregivers are 1.53 times more likely to develop depression compared to their male counterparts. Informal caregivers are part of the healthcare team. I want you to hear that. That's incredibly important. I need caregivers to understand who they are first and foremost, as Dr. Duncan mentioned. Caregivers are family, they're friends, they're unpaid caregivers. They are also very much part of the healthcare team. They attend to another person's health needs and well-being. They provide emotional support to people with Alzheimer's disease. They communicate and coordinate care with other family members and healthcare providers. They ensure at home and safety at home and elsewhere. And they manage health conditions. Caregivers are adults 65 years and older, women, 67% of them are women, 10% are Black, 8% are Hispanic, 60% are married or in a long-term relationship, 25% take care of a parent and a child at the same time, 50% take care of a parent or a parent-in-law, 23% are young and middle adults. Why do people become caregivers? Caregivers often cite love, a sense of duty, and obligation when describing what motivates them to assume care responsibilities for a relative or friend living with dementia. Another reason people become caregivers: mistrust and fear of neglect and abuse of a loved one. Based on caregivers' testimonials, they also desire to keep a family member or friend at home. They want to keep them in close proximity. The cost of caregiving. In 2020, 11.2 million caregivers of people with Alzheimer's or other dementias provided an estimated 15.3 billion hours of informal assistance, estimated again at $257 billion. Total lifetime cost of care for someone with dementia was estimated at $373,523. A caregiver spouse experiencing mental or emotional strain has a risk of dying that is 63% than that of spouses that age who are not caregivers, than that of the age of individuals who are not caregivers. There are benefits to caregiving. There's more quality time with the elderly person. They get in touch with family history. They affirm support networks within community and family, and it brings a deeper sense of one's own value. However, there are adversities associated with caregiving. There's burnout from constant caregiving tasks. There's depression. There's anxiety from stress related to the caregiving experience. There's financial strain from unexpected out-of-pocket costs. The needs of the caregiver must not be overlooked. We can't overlook this. To provide adequate support and mitigate burden, the World Health Organization recommends that caregivers be assessed for their needs. If attention is not given to the health of the caregiver will suffer adversity, and by proxy, the opportunity for the best health outcome for the Alzheimer's dementia patient is going to be limited. So let's talk about barriers to addressing caregiver needs. What can we do? So the World Health Organization has talked about the need for assessment. Are we assessing? Are we assessing caregivers? Well, healthcare providers can do a better job at assessing caregivers. There are many reasons that we miss opportunities for assessing caregivers. One of them, as Mr. Gibson and Dr. Duncan spoke about, bias. Bias can get in the way of assessing the caregiver. Time factors can get in the way. Healthcare provider identification of the caregiver, communication strategies that include caregivers, and recognizing alterations in caregiver roles. Not all caregivers will seek the support they need, and some may not even recognize their unmet needs. Further, some caregivers don't even recognize that they're caregivers. Does anyone relate to that? There are many people that say, well, I'm doing this because it's my wife, and till death do us part. Some people say, that's my mom, she did everything for me, I'm going to be there for her, it's not a problem, I'm just here. Caregivers can do a better job of identifying themselves. Just because the caregiver shows up to the doctor's appointment with the Alzheimer's dementia patient doesn't mean that the physician or the nurse practitioner sees them. It's important for the caregiver to advocate for themselves. And if the physician or the nurse practitioner hasn't said to the Alzheimer's patient, okay, we've addressed your needs. By the way, Mr. or Mrs. Caregiver, how are you doing? Right? How are you? How are you feeling? Is there anything you want to talk about? Don't wait for that, caregivers. If you have a need, if you have a question, if you just want to be screened, just to make sure that you're okay, you might have to ask for that. And here at this Caregiver Empowerment Conference, I want to encourage you, empower you to stand up for yourselves. Ask, advocate for yourselves. Solutions. Caregivers must be encouraged, again, to advocate for themselves. Via screening, healthcare providers must consistently seek to address the needs of caregivers to patients with Alzheimer's dementia. It takes a village. Caregiving for a loved one with dementia is a team effort. Remember, I said you're part of the healthcare team. We talked about the different things that caregivers do. They help manage medical conditions. They help to ensure the safety of their loved one. You are part of the healthcare team. Developing the tools to treat and cure dementia is a team effort. Our team is not complete without the caregiver. So, what's at the core of all of this? Would we have all of this adversity if we didn't have Alzheimer's disease to deal with? Maybe we need to get to the root of the problem. We've got a problem. Alzheimer's disease, dementia, is affecting the African American community 2 times longer, 2 times as much. And the Hispanic community, 1.5 times harder. We need to find answers to this devastating disease. And that's where my work comes in at the University of Miami. I'm so proud to say to you that we are addressing diversity in biological research to address this problem. We need your help. And caregivers, you can play a huge part in helping us find the answer to the root problem, which is Alzheimer's disease. 580,000 people aged 65 and older are living with Alzheimer's disease in the state of Florida. Black Americans, again, are about twice as likely to develop Alzheimer's disease as other dementias. As older white Americans, by 2030, 40% of all Alzheimer's disease patients in the U.S. will identify as Latino or Black. Treatment and management. There are currently no treatments. There is no treatment to stop or slow dementia. Medications are used to treat certain behavioral symptoms, delusions, depression, anxiety, muscle stiffness. So I'm not, because of time, let me just say that medicine in the future is going to be targeted therapy, based on targeted therapy. And right now, we don't have the numbers of participants in research to develop those therapies. That's why we need your help. We need more diversity in Alzheimer's disease research. We're going towards personalized medicine, genetic testing for diagnosing, better treatments, possibly prevention from the fruits of research. So caregivers, if you really want to address the root cause of this, help us. Help us find the solutions to this devastating disease by getting involved in Alzheimer's disease research. With our study, we do some cognitive testing with our individuals, and we take a blood sample. That's it. A little time invested to help us find some solutions. The one last thing I want to leave caregivers with again, help us as medical providers help you. Help us help you. When we miss an opportunity, when we fail to see you, we need you to stand up. Help us see you. You're empowered to stand up and say, I'm a caregiver. I need a little help. We're here to help you. Help us help you. Thank you.
Thank you, Miss Blair. That was very powerful. I mean, I'm sitting here and I'm thinking of some things myself. Speaking from a standpoint, a position as a caregiver, I know how hard that journey is. And we are, and I say that very passionately and proud to represent our caregivers, we are the advocates for our loved ones. But you are no good to your loved one if you don't take care of yourself. And it's okay to reach out for help and say, hey, I'm at my breaking point. I need help. And, it's so important. We have so many resources that are there, but they are not enough. And the only way that we're going to know what resources that you need, you have to let us know. It's so, so important because, research, this is such an exciting time in research. And you need to stay informed because I'm just going to drop this one on you. You need to be prepared for this. Blood biomarkers. That's around the corner, folks. What that means is that they're going to be able to determine by just taking a vial of blood whether or not you are at risk for this disease. That's amazing. Okay? And here's the thing. As a research champion, I consider myself to be the paparazzi for our researchers because you know what? These are some amazing folks that they're so focused on their research and they're very humble. But to be able to talk about their research and to be involved in it, it's so powerful. And today I had someone who heard me speak this morning. They asked me, and they are a caregiver. They said to me, Keith, how can I get involved? I said, you got to get involved in a clinical trial. Okay. I had another person speak to me today and said, I'm afraid to get myself tested. You need to lose that thinking. You're not alone. You're not alone. As long as you have an organization like the Alzheimer's Association with you, and organizations like this that put on this wonderful conference for you, take advantage. Get plugged in. Don't get unplugged. It's not the time. There's a lot of work, and remember, it takes a village. And I'm going to quote a line from one of the members of the University of Miami's team, Dr. Katrina Sellis. At a research conference, she shared this statement: inclusion is the solution. Let's say it together. Inclusion is the solution. And so this is such a good time. No one's going to be left out. And we want everybody to be at the table. So we care about you. And just know that you're not in this by yourself. So I'm going to stop here. And I'll turn it over to Miss Charlotte. And let's give Miss Charlotte Taylor a warm round of applause. This has been an amazing conference, okay? So she deserves every bit of that because, again, to bring the attention to highlight you caregivers, that's what it's really all about.
We have a couple minutes if anyone has any questions.
Yes, okay. Oh, okay. There you go. We have some questions. Do we need to?
Does anyone have any questions?
Oh, yeah.
We have a, Vivian, do you mind helping me out? Yeah, or not fall off in the middle of the thing.
I don't think I need a mic. I have a question at the biomarkers. My question is, I'm
Okay.
all good for the fear of being, doing the test. I had two parents with Alzheimer's. I also have an intellectual developmental disabilities brother. I can see the writing on the wall. My question is, what is this impact of doing biomarkers in the insurance carriers for future medical coverage?
Oh, can I answer that?
Go ahead.
Okay. I just learned this recently. When you suspect something is going on, before you get actually tested, go get the policy. Then you have a path going forward. I learned this recently. An insurance a representative from Allstate told me about the extended care plan, and she said to me, Keith, what message that you can give to the folks is when you suspect something going on, that is the time to go get that extended care plan. Because then, once you have that extended care plan, then go get the assessment. Because the moment that you get that assessment and it's now on record, that's going to impact your ability to get the coverage that you need.
And that being said, you get that extended health care, but what's going to happen is the future, every year you have an insurance, medical health insurance policy to sign up for once it's being covered through your employer. So now you're 65 years old, you're signing up for Medicare, then what?
In terms of
Establish markers. Now they're going to write it into your future health policies of waiving coverage for that particular.
yeah,
I'm so sorry, we'll only have time now.
That's
for
okay.
One or two more questions. So,
and I just want to comment. You mentioned something about the IDD. I want to share something with you. At a recent conference in San Diego, one of the researchers said that the solution for this disease will probably come from the IDD community. Just want to share that with you. Okay, that was it. Okay, I have one. Okay. Okay, the question was, we're over.
The medications, oh, thank you. The medications that he's given her are not working, but he's not listening to me. So, what resources out there for me to go and find out more about getting some help for her
Okay,
or medication to be
here's the
checked?
thing. If they ain't listening to you, change your doctor. Here's the thing. 3 years ago, every year the Alzheimer's Association publishes a report called the Facts and Figures report. And in this report, 3 years ago, they identified a barrier to getting a proper diagnosis as being physicians because these physicians don't have the knowledge base. So too often have I heard the horror story when a person goes to the physician and they give them some issues that they're experiencing. This is the classic go-to answer. Oh, well, there's not much I can do for you because you're getting old. That's a cop-out answer. And if you cannot have a wholesome discussion with your physician, change, okay? Because you need to be able to have that relationship where you can have those honest and hard questions. And also, too, that your physician is not afraid to make the necessary referral to the neurologist and to a psychologist. That is a problem because physicians, and I know we're out of time, but I'm just simply share this. My brother, when he had those two major medical events of a stroke and a heart attack at the same time, well, the heart was severely damaged. Okay? The stroke left my brother paralyzed on the left side. They said, well, for the heart, two options: heart transplant or medications. Well, the heart transplant was out because we couldn't afford that. So medication. Then the stroke, okay, physical rehab, that's all we can do. So I'm like, that's it? I said, my brother's changed. I need to get a complete workup. I said, is it possible to get a referral to a neurologist and to a psychologist? The primary care physician said no. I said, wait a minute. It's not about you. It's about my brother. Okay? And after advocating as a caregiver, I was able to get them to make the necessary referrals so that I could come up with a care plan for my brother. So again, just notice in closing, to get a diagnosis, a probable diagnosis, it involves a primary care physician, a neurologist, and a psychologist. One doctor by themselves cannot make that probable diagnosis. And too often do I hear the word dementia. Oh, they have dementia. If you tell me that I have dementia, I'm going to say, what type of dementia? Just like if someone says to you have cancer, you're going to say, what type of cancer do I have? So you need to be able to get those answers that you need. Okay, I know I'm out of time, but this is good stuff.
Just add to that real quick. Just very quick, I want to add to that. I have to say, remember, you are part of the healthcare team. We need you. We need your ideas. We need to know what you're thinking about in order to have the best health outcomes. So as caregivers, if the mindset is, well, I'm part of the team, then you would expect to be heard. And all of you need to expect to be heard. Your opinions matter.
Thank you. All of you are awesome. Thank you so much. Dr. Duncan, Nurse Karen, Keith Gibson, thank you, all of you.